Hello, ladies and gentlemen, and thank you for joining us for another webinar from the Brain Aneurysm Foundation. Our tonight's guest is Dr. Aman Patel from Massachusetts General Hospital. He's a talented neurosurgeon with special expertise in endovascular neurosurgery. He's going to be talking to us about some of the cutting-edge technologies in this arena and what the patients need to know about this method of treatment. Aman, thank you for joining us.
This evening, and it's nice to see a nice crowd here. As Aaron mentioned, I am here at Massachusetts General Hospital, and I'm a neurosurgeon who's trained in both open and endovascular techniques. And what I'd like to do is a review of the endovascular options that are available for the treatment of cerebral aneurysms. So to begin, just a quick review. Intracranial aneurysms affect 1.5 to 8% of the general population, so it means that quite a bit of people are walking around in the country with unruptured aneurysms. Fortunately, we only see about 30,000 ruptures per year in the United States, so it means that the vast majority of these aneurysms will not bleed. So the trick for us, for patients and for doctors, is to try to determine which aneurysms pose the highest risk for rupture in the future if you present with an unruptured aneurysm. The peak age of rupture is between the ages of 40 and 70, but this can affect people of a wide variety of ages. Females outnumber males, and 20% of patients have multiple aneurysms, and as listed here, there are a variety of disorders that are associated with aneurysms. Many of you are patients, and you may have heard these terms. The common locations for aneurysms, the two most common are the anterior communicating artery and the internal carotid artery and posterior communicating artery. The middle cerebral artery is the third most common, and then 10% of aneurysms are located in the posterior fossa. So the general treatment options for intracranial aneurysms include conservative management. As I mentioned, a lot of unruptured aneurysms have a very low risk of bleeding, and so it is not an unreasonable treatment option to monitor these aneurysms, especially if they're small-sized in certain locations that have low risk of hemorrhage, or if the patient is much older. The natural history of bleeding may be low enough that the lifetime risk is quite low. As I mentioned earlier, we see about 20 to 30,000 subarachnoid hemorrhages per year. I think the number is closer to 30,000 per year now. So the overall risk of rupture of an unruptured aneurysm is relatively low, so conservative management is a good option. The other two options would be craniotomy for clipping and endovascular embolization. In this talk, I'd like to focus on the endovascular options that are currently available as of November of 2014. In my opinion, being a doctor who does both modalities, the advantages of embolization are that it's less invasive, overall complication rates are lower, there's a shorter procedure. With unruptured aneurysms, there's a shorter hospital stay. If you present with a hemorrhage from your aneurysm, the hospital stay is essentially the same between the two modalities, especially given the fact that your hospital stay is more based upon disease rather than the treatment. You get to avoid a craniotomy and some brain manipulation. The disadvantages are there is a slightly higher recurrence rate with embolization, and not all aneurysms are amenable to embolization, so selection of the aneurysm is very important. And if we treat unruptured aneurysms or people who are not very sick, the goal should really be to close the entire aneurysm, and you should try to establish that goal, even if that requires craniotomy and clipping. So what do we do with embolization currently? The current endovascular treatment involves filling of the aneurysm with embolic material or diverting the flow away from the aneurysm using a catheter system that we visualize using X-ray fluoroscopy to guide